Welcome back to Corium. I'm Brian Gilberti, and today we're revisiting a topic that we covered 8 years ago, sexually transmitted infections or STIs. A couple of important components of care have changed since then, and to help us navigate these updates, we have Dr. Avir Mitra with us. Now, Dr. Mitra is an associate professor of emergency medicine, as well as being a veteran podcaster with multiple cameos on Radiolab, and already had his inaugural one on ours. So great to have you back on, Avir.
It's great to be here. I'm excited for this topic.
Now, STI is always a very relevant topic in the emergency department, and there's going to be a lot to discuss today. We're going to start the episode by covering some of the most common STIs, and for the listeners to provide them with some scaffolding for this episode, we're going to talk about each pathogen's presentation, testing, and treatment, and try to highlight any relevant updates. Now, Avir, let's start with the most common STI, chlamydia.
Yeah, let's start with chlamydia since that's the most common STI. So, how does this present? I think we mostly know this, but remember that a ton of these, a big percentage, can be asymptomatic. Or you can have urethritis, or you can have cervicitis. This can develop to PID. It can be prostatitis, proctitis, or in the pharynx, so pharyngitis. So I think we're all very accustomed to thinking about this in the genitals, but also we need to think about triple swabbing in the right patient, in the throat, and in the rectum.
Exactly. And as you mentioned, Avir, many cases are asymptomatic, with studies showing that anywhere from 40% to as high as 96% of patients show no symptoms. This presents an epidemiologic challenge because asymptomatic individuals can act as reservoirs for the infection, which is part of the reason why chlamydia remains the most common sexually transmitted infection. So, Avir, can you talk to us about testing?
The gold standard at this point is nucleic acid testing. That's going to be PCR, so you're going to have a very sensitive test. But the question is, where are you going to get it from? You can get it from the urine, which is good. It catches most. But if you actually do an endocervical swab or urethral swab, the sensitivity is better. And like I said before, if someone's having oral symptoms or rectal symptoms, make sure to swab there as well.
Yes, and we should highlight the sensitivity of these tests, which varies depending on the sampling site and method. Endocervical swabs generally have slightly higher sensitivity for chlamydia infection than urine samples, identifying up to 10% more infections. While first catch urine is a non-invasive option, it may show slightly reduced sensitivity compared to vaginal or endocervical swabs, particularly in females. Additionally, nucleic acid amplification tests on urethral swabs provide reliable sensitivity, especially in symptomatic patients. Now, these tests take time to process, and we don't have the results available while patients are in the emergency department. But let's say we have a patient in whom we suspect a chlamydial infection. What are our treatment options?
Okay, so the treatment used to be 1 gram of azithro once, but due to increasing resistance, the first-line treatment is now doxycycline, 100 milligrams, PO, BID for 7 days.
Very good. And that's going to differ from PID, which we're going to get to in a bit. Now, just to round this out, Avir, what's second line here?
If you have a patient that you don't think will be able to adhere to the regimen for a week of doxy, you can still give azithro. That's sort of a second-line option now.
Yes, and also in pregnant patients. Okay, now let's move on to gonorrhea.
All right, gonorrhea. So, just like chlamydia, gonorrhea can be asymptomatic, can be urethritis, cervicitis, prostatitis, proctitis, PID, or it can be in the pharynx.
And this underscores the importance of comprehensive swabbing at 3 sites, not just for chlamydia, but also for gonorrhea. We need to assess both above and below the diaphragm to avoid missing an infection. Now, let's move on to the current treatment recommendations for gonorrhea.
So gonorrhea treatment has also changed recently. It used to be 250 milligrams of ceftriaxone with a gram of azithro. And now, due to increasing azithromycin resistance and also a better understanding of the PK values for ceftriaxone, the first-line recommendation is 500 milligrams of ceftriaxone once, IM.
Now, as you implied, chlamydia and gonorrhea frequently coexist, with co-infection rates estimated between 20 and 40% in certain populations. This overlap makes it critical to treat both infections if one is suspected, as untreated co-infections increase the risk of complications like PID, which can result in infertility. The CDC recommends empiric treatment for chlamydia whenever gonorrhea is detected, given the likelihood of co-infection and the need for comprehensive infection control. Okay, circling back, talk to us about how management differs for PID.
So PID has also changed. I should say that a lot of the stuff we're talking about, a lot of these changes are coming from the 2021 CDC updates to STI management. When it comes to PID, there was an update there as well. So it was always thought that PID was due to either gonorrhea or chlamydia. But we're increasingly finding out that about 50% of PID cases are not due to those STIs. Many of those other cases are due to BV or due to other random anaerobes. So there's an increasing recognition that just treating for STIs is not enough to manage PID. So the treatments there have changed as well. So the treatment now is going to be ceftriaxone 500 once IM, doxycycline 100 milligrams PO, BID, but for 14 days, not just 7 days, plus metronidazole 500 milligrams PO, BID for 14 days. So it's a 14-day treatment, and it includes Flagyl, metronidazole, to recognize that a lot of these PID infections are being caused by BV or other anaerobes.
Okay, and now moving on to the great imitator, syphilis. And as its nickname suggests, can present in many forms depending on the stage of illness. So, Avir, walk us through the early diagnosis and touch on why early detection is so crucial in these patients.
So syphilis, it's been around forever, but it still requires some nuance. So you have your primary stage. That's the easy one. You have a painless chancre. You're going to see it on the genitals, and you're going to treat with penicillin G 2.4 million units IM single dose. Okay? If you didn't catch it then, they're going to come in with secondary syphilis. Now, this is one that I see residents and students missing all the time. These patients are going to have a rash on their body, little nodules all over their body that are difficult to otherwise explain. They could also have very non-specific joint pain. So if you see that, test for syphilis, and you can still treat with the same treatment, penicillin G 2.4 million units IM single dose. So if you missed the primary and secondary, now you go into the latent phase. All the chancres, all the physical exam findings are gone. The person's asymptomatic. So this is when it gets challenging. You send a syphilis test and it's positive. There's two subphases of latent. It can be early latent, which means you got it within the last year, or late latent, which means any time after that. What I find is that most of the time you have no idea whether it happened in the last year or later. So the treatment for late latent is actually to do penicillin G 2.4 units IM, but you have to do that 3 times, once a week for 3 weeks. So my recommendation is if you see an asymptomatic person with syphilis and you're not exactly clear on when this happened, if this is reinfection, you don't know what's going on, you probably want to do 3 doses spread out a week apart.
Perfect. Great rundown of treatment protocols for different stages of syphilis. Now, could you shed some light on neurosyphilis and what clinicians should be vigilant about in these cases?
So neurosyphilis is essentially those treponema bacteria entering the central nervous system. It used to be thought that that could only happen late in the course, but infectious disease is increasingly recognized that this can happen pretty much at any time. It can even happen in primary syphilis, certainly in secondary syphilis, in latent, or even tertiary. So it can happen anytime. It's sort of a branch that can come off anytime. So in any patient that you're suspicious of or diagnosed syphilis, you always want to ask about any visual changes, any ocular involvement, or any strange neurologic symptoms. Headaches, but not just like regular headaches, but I never get headaches and now I just have this terrible head pain all the time. Those are the patients that you want to be suspicious for neurosyphilis. Those patients are going to need an LP, and if positive, will need admission for IV penicillin.
Yes, and as you mentioned, this is a challenging condition to work up because even diagnostic tests can come back negative. But if there's a high level of suspicion, we should proceed with treating for neurosyphilis, which would require admission.
So in patients with tertiary syphilis, now this is years down the road that they haven't been treated, are going to come up with all those obscure signs and symptoms and findings that are very rare. The Argyll-Robinson pupil, tabes dorsalis, aortitis, aortic dissections, aortic aneurysms, saddle nose deformity, and gummas.
Just to name a few, right? Now, it's an exceedingly rare process that at this point mainly lives in textbooks and on board exams for us, But it's one of those diagnoses that we shouldn't miss, and it's going to take a well-caffeinated doctor to pick up on this. But if we do pick up on it, then that too requires penicillin G, 2.4 million units in multiple doses. Okay, so that's syphilis, a hefty part of our discussion, and deservedly so. Now let's switch gears to talk about a parasite, Trichomonas. Is there anything new here, and what are the typical symptoms for trichomoniasis?
So nothing too new with Trichomonas. It can be asymptomatic, or it can cause vaginal discharge in women. It can sometimes cause urethritis in men. The diagnosis used to be wet mount. I've never seen a microscope in an ED to do that. But now we have the nucleic acid test. So you can get a very great test. Again, you can do it off the urine. If you can get a swab, that's much better.
Okay, and let's say we do have a test that comes back positive. What are you giving these patients?
Okay, so the treatment used to be metronidazole 2 grams PO just once. And that is still, according to the 2021 guidelines by the CDC, that's still acceptable for men. But for women, the recommendation is 500 milligrams PO BID for 7 days.
So 2 important things to point out here. First, there's a relatively newer diagnostic method. Instead of relying solely on wet mount microscopy, we're now using a nucleic acid amplification test, and treatment for women will differ. It requires a longer course of 500 BID for 7 days. So that's trichomoniasis. Now, Avir, time to talk about herpes.
So herpes, I think most people know you have HSV1, HSV2. Traditionally, HSV1 used to be oral, HSV2 used to be genital. But recently they've mixed it all up and you're getting a lot of genital HSV1 and you get some oral HSV2. You can find either in either place, basically. Now, serum testing for this is really not that useful. You have your IgG and IgM. Anyone who's ever had a cold sore or ever had herpes is going to be positive on the IgG, so that's not that useful. And IgM, it may be falsely positive, it may be falsely negative. It's not a great test for the diagnosis of acute HSV. So what we recommend instead is to do PCR testing to swab a lesion if you see it. So if you see a lesion and you know what it is, you can just go ahead and treat it. That's fine. But if you're not sure, go ahead and swab it and see. And if it is positive, you're going to treat with valcyclovir, Valtrex.
Okay, and that's just one of the options. It's the preferred one in a lot of cases because of the less frequent dosing than acyclovir, allowing patients to follow the regimen more easily. But acyclovir is a more affordable option if there are any cost-based or insurance-based barriers to accessing medications. And we usually treat for 1 gram daily for 7 to 10 days for an initial episode, or just 5 days if treating a recurrence. All right, so that covers HSV. Now on to HIV. What are some of the things that we should keep in mind when a patient presents with potential HIV or even an acute HIV infection?
Well, I think we're doing a great job in emergency departments screening for HIV, so that's great, but we should know the limitations of the test. And these tests, depending on which one you use, all have different window periods. And that means that the person may have acquired HIV, but their test won't be positive at the time that you test it. So it can be anywhere from 2 weeks up to almost 3 months, depending on which type of test you're using, that you could be in a window period where your test is falsely negative. So what do you do about that? If you have a patient coming in with the right story and you're concerned for acute HIV, so they're having flu-like symptoms, malaise, joint pains, fatigue, and nothing else is really making sense. Flu swab is negative, COVID swab is negative, and you think this could be HIV, you should know that your HIV test, if you were to send it out, will be negative. So you can either empirically start treatment and have them come back for repeat testing in a few weeks, or you could send out a HIV viral load. Now, that's kind of an expensive test. It'll take a few days to come back, but that viral load will be positive at that point, and that would confirm your diagnosis.
Great, and this is an important point here about the window periods and limitations of our HIV tests. Now, given early detection can be challenging, Avir, what should we do when a patient presents shortly after potential exposure, and how should we approach post-exposure prophylaxis in these cases?
So PEP is a great thing. We want to start that on as many patients as possible. I think this is a big part of emergency medicine now. Ideally, we'd like to start PEP within 72 hours of exposure. That's great. If someone comes in over that, am I going to not start PEP? No, I'm going to still do it, but ideally, I'm doing it within 72 hours. I think the most important thing to remember is that these patients are going to take PEP for 28 days. You want to send out some basic serum testing beforehand. obviously you want to send an HIV test, and that's not going to tell you if they're positive from this exposure. That's going to tell you if they already had HIV. You're going to want to send renal function and hepatic function to just make sure that there's no side effects to the PEP that you're about to start. And then you'll want to get that rechecked in about 2 weeks to make sure nothing's changing. There's no adverse effects to the medicines.
All right, so far we've covered chlamydia, we've covered gonorrhea, we've covered syphilis, trichomoniasis, HSV, HIV. Avir, who's the new kid on the block here?
All right, so in 2021, this was a big year for STIs. The CDC came out with a brand new official STI. It's called Mycoplasma Genitalium. Now, this is something that's been recognized, tested for, and treated in other countries, Australia, Japan, for several years. But in the US, it wasn't something that we were really officially testing or treating for. So Mycoplasma Genitalium is an interesting one because it doesn't have a cell wall. It's hard to culture. But with the advent of nucleic acid testing, we're seeing it a lot more. And we're seeing correlations with symptoms. So I should say that when we're talking about Mycoplasma Genitalium, you may see tests for Mycoplasma hominis or ureaplasma. Some doctors are sending those out. That is not what we're talking about. And there is no clear correlation between those infections and symptoms. But in Mycoplasma Genitalium, there is a clear correlation. So the CDC has recognized that Mycoplasma Genitalium can cause cervicitis or urethritis. There is some evidence to show that it may cause PID or proctitis, but as of now, we're not certain about that. So what we do know for sure is that Mycoplasma Genitalium can cause cervicitis or urethritis.
Okay, interesting. So this brings up another important issue. How do we go about testing for these infections? What are the recommended methods for accurate diagnosis here?
So this is where it gets interesting. The CDC recommends that we only test for Mycoplasma Genitalium if someone is having continued symptoms despite negative testing for all other STIs, or continued symptoms if you've treated them and their symptoms haven't resolved. So if someone comes in with brand new symptoms, you should not be testing for Mycoplasma Genitalium. But if someone's coming in saying, hey, I took all the medicines you gave me and it's still not working, or hey, you tested me for everything, it was negative, but I'm still having symptoms, then you want to send a nucleic acid test for Mycoplasma Genitalium.
Yes, and that's an important consideration. Knowing when to test for Mycoplasma Genitalium can really impact patient care. It always underscores the need to inform patients about the possibility of a persistent infection and the importance of following up if symptoms continue. So if a patient does return with ongoing symptoms, Avir, and we suspect Mycoplasma Genitalium, how does the treatment differ for this infection?
Okay, so to treat Mycoplasma Genitalium, you're going to give 1 week of doxy, 100 milligrams BID for 7 days, followed by 1 week of moxifloxacin, 400 milligrams daily. So in a way, it kind of works, right? Let's say you treated someone, you gave them ceftriaxone, they took a week of doxy, it's not working, they come back, now you just start them on the moxifloxacin right away.
Avir, we've covered a lot today, really some of the essentials and pertinent updates, but there's so much more. Let's go over some take-home points. First, when treating chlamydia, doxycycline 100 milligrams PO BID for 7 days is now the first-line treatment for cervical infections and 10 days for epididymitis, replacing azithromycin due to increased resistance. And for gonorrhea, we treat with a single dose of 500 milligrams IM ceftriaxone. PID management has also changed, with expanded antimicrobial coverage now being recommended. 500 milligrams IM ceftriaxone, doxycycline 100 milligrams PO BID for 14 days, and Flagyl 500 milligrams PO BID also for 14 days. Mycoplasma genitalium is a newly recognized STI. Test for this in patients with persistent symptoms after standard treatment. If it is diagnosed or suspected, treat with doxycycline 100 milligrams PO BID for 7 days, then moxifloxacin 400 milligrams PO daily for 7 days. Finally, be aware of the HIV testing periods. A negative result doesn't always rule out recent infection, and consider HIV viral load testing. Initiate post-exposure prophylaxis within 72 hours for 28 days, and make sure that the patient has a clear discharge plan and support. Okay, that'll do it for this episode. Avir, thanks for coming back on the show.
Thank you for having me.